All right, future nurses, let's talk about lower respiratory infections. In particular, let's talk about pneumonia. So let's start out with a little case study here. So Mariah is a 54-year-old smoker. She has a productive cough with yellow sputum. She has left-sided chest pain. Upon physical exam, she has a fever, tachycardia, and tachypnea. So fast rate of breath, fast heart rate. Lung sounds with the stethoscope are barely audible. There are, however, crackles at the left base of the lung. Chest x-rays show left lower lobe infiltrate. Notice that the pain and the location of the infiltrate match perfectly. Now let's consider a second patient, Jeremy. Jeremy is a 64-year-old chap. He was hospitalized for a stroke 2 weeks ago. He has recently developed a cough and right-sided chest pain. He is tachycardic. He has a fever of 38.4 centigrade, not unlike Mariah. Physical exam shows fremitus, decreased breath sounds, and dullness to percussion in the chest, in the right lower lung field, and X-ray shows infiltrate in the right lower lobe of the lung. Again, where the pain is and where the infiltrate is located match rather well. That also matches with the dullness to percussion and fremitus and so on and so forth. So these folks, both of them, have pneumonia. So pneumonia, very simply, is an infection of lung tissue. An infection of lung tissue. It's an infection of the bronchioles, both terminal and respiratory, potentially, and the alveoli. This generates an immune response. The immune response brings white blood cells, dead bacteria, proteins, and fluid into the alveoli and bronchioles. This mixture of materials is called an exudate. If you cough it up, it's known as sputum. If the exudate stays in the lung, it fills the alveoli. So there's many, many ways to classify pneumonia. Here are two based on symptom presentation. So there's classic pneumonia or classical pneumonia. The signs and symptoms of classical pneumonia include dyspnea. That simply means a shortness of breath, fatigue, fever, pleuritic chest pain, and this pleuritic chest pain is characterized by a sudden and intense, sharp stabbing or burning pain in the chest when inhaling or exhaling. And then also a productive cough that tends to produce yellow sputum. Other signs include a dullness to percussion. So I'd like you right now, if you're listening, to go ahead and drum on your chest. Go ahead. Do you hear the kind of drum-like sort of sound, drum-like quality to it? If your lungs are filled with liquid instead of air, it will lose that drum-like quality. Now, another sign is so-called tactile fremitus. In this case, you have increased vibrations when you place your hand on the patient's chest or on their back. And the consolidation in the lung will cause increased vibration if they say either 99 or blue moon. Go ahead, put your hand on your chest right now, say 99, 99. Then say blue moon, blue moon. You can feel the resonance, but if someone has pneumonia, you're going to feel a great deal more of vibration. If you auscultate the area with your stethoscope, the 99 will sound louder. This is called bronchophony. Bronchophony. This occurs because sound waves and vibrations travel better through fluid-filled consolidated tissue than they do through air-filled tissue. For a similar reason, when you put your stethoscope on the area with the consolidation, you can hear a bronchial breath sound where the sound of air moving in the bronchi is transmitted clearly through the fluid-filled consolidated area. This is a higher pitch sound and louder than normal vesicular breath sounds where the sound waves pass through more air-filled alveoli. With increased resonance in the area with consolidation, when the patient is asked to say the letter E with your stethoscope on the chest wall, it will sound like A. Instead of E, it will sound like A. And if you have your stethoscope nearby, go ahead, take it and put it in your ears and listen to your chest while you say E. Go ahead, E. E. Do you hear it? Does it sound like E? If it's just consolidated and filled with fluid, that E will sound like A. Instead of E, you'll hear A. That's called egophony. Egophony. Inspiratory crackles can be heard over the affected area. Crackles. Crackles are popping lung sounds. They're made when air passes through the fluid in the collapsed alveoli. And finally, people with pneumonia, because of autoregulation of breathing and heart rate, breathing rates and heart rate, will have tachypnea and tachycardia. There are some other ways to categorize pneumonia according to what causes pneumonia. Oh, let me say, first of all, these are the signs and symptoms of classic pneumonia. With atypical pneumonia, you won't have these signs. Instead, you may have very general sorts of symptoms like a sore throat, a headache, a dry cough, something like that. Now, atypical pneumonias very often are caused by Mycoplasma pneumoniae. You see this organism when people are tightly packed together, for example, in prisons or in the military barracks or something like that. Mycoplasma pneumoniae are organisms or prokaryotes, they have no cell wall. So they will not stain with a gram stain. They will be there'll be no gram reaction. They don't grow on traditional augers. You can grow them on Eaton's auger, which is supplemented with cholesterol and nucleic acids. It takes like 2-3 weeks for these colonies to form, and they look like small fried eggs. Because of that, culture is usually not used. Again, they will not gram stain. So if you have some sort of exudate, you don't get a gram stain, it might very well be Mycoplasma pneumoniae. You're going to see very generalized symptoms: fatigue, mild fever, dry hacking cough. There's a very good test for this. It's called the cold agglutinin test. Because this organism has no cell wall, antibodies against the membrane tend to react to our own white blood cells. So B cells produce IgM antibodies. They cross-react with red blood cells. They cause agglutination of red blood cells in the cold. So you take some blood from the patient, you put the test tube in a box of ice, and the blood will clump. You can do this test at the bedside. It's called a cold agglutinin test. Treatment, Mycoplasma pneumoniae, is with macrolides, usually a Z-Pak, 500 milligrams of azithromycin the first day, 250 the next 4 days, so 5 days total treatment, or doxycycline, 100 milligrams BID, usually for 7 to 10 days. We'll clear this up. Very often, atypical pneumonias will resolve on their own. Atypical pneumonias very often are called walking pneumonias because people are not bedridden with this type of pneumonia. Another cause of atypical pneumonia is an organism we'll talk about more called Legionella pneumophila, which is important in hospitals because it can come in through the cooling system in hospitals. So we'll talk more about that. That also causes an atypical pneumonia that's more severe, but you won't see organisms that stain with a gram stain because Legionella doesn't stain well with the gram stain either. Very good. They can also classify pneumonias according to the organisms that cause them. So with a bacterial pneumonia, it's caused by bacteria, most commonly Streptococcus pneumoniae, Haemophilus influenzae, or Staphylococcus aureus. You can also have viral pneumonias that are caused by viruses. There's several viruses that can cause pneumonia. Definitely the most common is influenza virus. Viral pneumonias will tend to have an abrupt onset. And they can also cause secondary bacterial pneumonias because they will weaken the immune system and the lungs. Walking pneumonias will be caused by Mycoplasma pneumoniae, but they'll also be caused by other organisms. So, Chlamydia pneumoniae, sometimes this organism is called Chlamydophila pneumoniae. Different books say different things. Some say Chlamydophila, others Chlamydia. Others once said Chlamydophila, now they're back to Chlamydia. You'll see both. So if you see pneumoniae, that's what it is. This organism, like Chlamydia trachomatis, is an obligate intracellular parasite. It is gram-negative, so it has peptidoglycan and lipopolysaccharide, but it does not stain with a gram stain. Instead, it will stain with a Giemsa stain. And it'll form little blue or reddish blue inclusions inside cells. Inside cells. So as we said before, you have an elementary body. It's taken up by a host cell. This is the infective agent. It transforms into a reticulate body. These divide inside the cell. They fill the cell, they cause lysis, and they will cause also a walking pneumonia. There are good nucleic acid amplification tests for this organism. You will not be able to culture it. Treatment of choice is doxycycline, 100 mg BID, 10 to 14 days. There is a related organism that can cause an atypical pneumonia. This is Chlamydophila psittaceae. This organism comes from birds. It comes from psittacine birds, like parrots and other birds related to parrots. This is also diagnosed the same way. You won't find this in a gram stain. The big tip-off here is going to be if your patient has a psittacine bird. Now, the other cause of atypical pneumonia is Legionella pneumophila. It's gram-negative, but it stains very poorly with safranin. So you usually will not see this in a gram stain for reasons that are not clear. It's a tough organism to grow. You have to use this buffered charcoal yeast extract medium that's supplemented with cysteine and iron. It comes from contaminated water, and in hospitals that'll come from the cooling systems. It is a parasite, intracellular parasite of the freshwater amoebae that you find in fresh water. So it infects patients through aerosols, very commonly in hospitals, through the cooling systems in hospitals. It can invade macrophages. The macrophages can't kill it. So it'll cause a pretty high fever of around 104 degrees centigrade. Can also cause GI systems. There is a urinary antigen test for Legionella pneumophila that works very well. It also causes a less severe Pontiac fever that's very flu-like. This usually resolves on its own. This one usually you have to treat. So you get some GI symptoms too, nausea, vomiting, that sort of thing. You treat this with azithromycin, usually a Z-Pak, or levofloxacin. And levofloxacin usually, levofloxacin normally you treat for 5 to 7 days. So these are your agents that cause your atypical pneumonias. Now, your pneumonias can also be classified according to the ages of the patients, and at different ages, different organisms will tend to cause pneumonia. So if your patient is younger than 4 weeks old, the most common causes of pneumonia are Group B streptococci. This is Streptococcus agalactiae. In virtually every case of Streptococcus agalactiae pneumonia, it acquired this from the mother. So those of you who work in labor and delivery, if a mother tests positive for this organism, she should be given prophylactic antibiotics before she delivers. Also, Escherichia coli. These are the two main causes of pneumonia in these very young patients, infants. If your patient's between 4 weeks and 18 years old, then your most common cause of pneumonia are respiratory syncytial virus, and chlamydia trachomatis, or usually up to 3 weeks, and then chlamydia pneumoniae for school-age children, and then streptococcus pneumoniae as well. Respiratory syncytial virus destroys some cells, causes other cells to fuse into a multinucleate syncytium, and the virus will cause a pretty respectable inflammation, and it also causes the airways to secrete lots of mucus. It makes the airways very leaky, so you get fluid, mucus, inflammation in the airways, and it tends to clog the airways. That's the reason why children disproportionately suffer from bronchitis with respiratory syncytial virus. If this infects adults, which usually adults are immune to it because they had the infection when they were kids, it usually doesn't cause a very severe disease and usually is of no consequence. (18 to 40 years, most common causes of pneumonia are mycoplasma, Chlamydophila, usually psittaci, Streptococcus pneumoniae, and then influenza as well. For patients 40 to 65 years and older, it's Streptococcus pneumoniae, sometimes anaerobes, and then also viruses. If you hear at rest homes about people dying from pneumonia, pretty safe bet that that older patient died of Streptococcus pneumoniae pneumonia. IV drug users, most common causes of pneumonia are Staph aureus and Streptococcus pneumoniae. And then your immunocompromised patients are a class unto themselves. And the most common causes of pneumonia in this group are Staphylococcus aureus, enteric gram-negative rods, and viruses. Organ transplant patients, the most common cause of pneumonia is cytomegalovirus. And in those patients, you'll tend to see pneumonia with intranuclear and cytoplasmic inclusion bodies. Intranuclear and cytoplasmic. You see that, it's cytomegalovirus. And then in patients with HIV, if they're CD4 cells, remember, these are your T helper cells, go below 200 cells per milliliter of blood, then their pneumonia is usually caused by pneumocystis urovecii, and that's pneumocystis pneumonia. If you have patients who have either traumatic brain injuries of some sort, or if they're alcoholics or drug abusers, or we could add to this stroke patients, who have trouble swallowing. So if they breathe in food or drink or even gastric contents, they can suffer from aspiration pneumonias. These types of pneumonias tend to be mixed infections. However, if your patient's a diabetic, the most common cause of pneumonia, aspiration pneumonias in diabetics is Klebsiella pneumoniae. So treatment of these is a challenge sometimes. Pneumonias are also classifiable according to what part of the respiratory system are infected. So bronchopneumonias are patchy pneumonias. You have the bronchioles that are infected and the alveoli, but it's patchy here and there throughout the lung. Interstitial pneumonias are infection of the areas outside the alveoli, the interstitium outside the alveoli. And then lobar pneumonia is infection of an entire lobe or sets of lobes of the lung. Pneumonias also be classified according to the place from which you acquired them. So community-acquired pneumonia is definitely the most common type of pneumonia, and Streptococcus pneumoniae is almost certainly the most common cause of community-acquired pneumonia. And you have hospital-acquired pneumonias. Hospital-acquired pneumonias refer to pneumonias that have been acquired in a healthcare setting after 2 days of, so 2 days is the biggie there. If you get pneumonia after that, then you have an HAP. These are also called nosocomial pneumonias, and the most common cause of these pneumonias are methicillin-resistant Staph aureus. The most common source of methicillin-resistant Staph aureus is the hospital staff. Yeah, hospital staff. So, folks, and hygiene. Masks, PPE, hands, face, space. Don't forget to ventilate. You can limit the spread of this in your patients. Also, Legionella pneumophila from the cooling system. These are the two main causes of hospital-acquired pneumonias. A subset of hospital-acquired pneumonias are ventilator-associated pneumonias. In this case, you get biofilms that form on the respiratory tubes. They tend to occur if the patient's been intubated more than 48 hours. So your culprits here are Staphylococcus aureus, either methicillin-resistant Staph aureus, sometimes methicillin-sensitive Staph aureus. But if in the hospital, typically your main culprit is going to be this beast here. Also, sometimes you can have enterics occasionally, or Staphylococcus epidermidis, which can also form biofilms on trach tubes, and then Pseudomonas aeruginosa. All right, let's talk more about lobar pneumonia. Lobar pneumonia occurs in stages. Stage 1 is congestion, and that occurs over day 1 to day 2. Your blood vessels and alveoli are going to fill with excess fluid. That's your congestion stage. They become congested. Second stage occurs day 3 to day 4. It's called red hepatization. Now you get an exudate that fills alveoli. That's composed of red blood cells, neutrophils, and fibrin that will fill these air spaces, causing them to become solid. That's red hepatization. Day 5 to day 7, the red blood cells break down, and now this material turns gray. That's called gray hepatization. And then day 4 is resolution, if provided your patient doesn't take a turn for the worse. Enzymes and macrophages. These will degrade the exudate and the lungs are returned back to normal. Those are the stages of lobar pneumonia. Let's talk about diagnosis. So your biggie is a chest x-ray. So with a chest x-ray with bronchopneumonia, you'll have patchy areas around the lung. You'll see congestion with the bronchopneumonia. Also the bronchial, you'll see some of the trees going into the lungs, the terminal bronchi. They'll be affected, but again, it's patchy. With lobar pneumonia, you have single lobes or sets of lobes that show consolidation. With interstitial pneumonia, you have a web-like or kind of reticular appearance, and it's concentrated in the perihilar area of the lung, interestingly. This can be easy to miss, although trained radiologists can easily see this. But if you don't know what you're looking for, this can be easy to miss. A sign on a X-ray of pulmonary edema, you see an outline around the periphery of the lungs. That's called a curly bee line. That is a sign of pulmonary edema, which is characteristic of pneumonia. Sputum can be cultured. You can gram stain the sputum. CBC should show increased white blood cells. You should also show increased signs of inflammation. CRP should be up, so should procalcitonin. That should also be up. These are all signs of inflammation. If your patient has HIV or if they're immunosuppressed, if they have pneumocystis pneumonia, you'll see disc-shaped bodies, and you have to stain the tissue with methenamine silver stain. That's a common feature, a common test of a lung biopsy or a bronchopulmonary lavage. You'll see disc-shaped bodies. This is a fungus, so it doesn't respond to antibacterials, but it does respond to sulfa drugs, which we'll get to in just a bit. Let's talk about treatment of pneumonia. Of course, it's going to depend on the type of pneumonia. Typically, Augmentin is used, so 875 mg twice a day, treat for 10 to 14 days. If you have sputum, you want to make sure the sputum is negative. Streptococcus pneumoniae, if you're treating empirically and you want to make sure you hit